Thanks for joining this morning. We're going to talk about human-centered design, why it's so important for technology, especially in inpatient. You're going to hear from a lot of different types of stakeholders, which I think is super important, on how we leverage technology, data, in order to improve outcomes for inpatient, and especially in inpatient, including all stakeholders, nurses, psychiatry, psychologists, those with lived experience. Incredibly important because it's a very nuanced environment, difficult environment to understand process, systems, and so we're going to talk about that. And we were joking, we were like, we actually really want to talk to you all about that. So participate and ask questions, and we're going to do about 15 minutes for every talk, and then we'll have Q&A after each talk, but then we'll also do a panel discussion at the end. So really be thinking about this issue and inpatient, how we can use existing technologies, but then also how we could potentially design new technologies as well, but always at the core, having the patient at the center. And I think that sometimes can get lost with technology. I see a lot of technologies now that have been designed without participatory co-development with patients, nursing, psychiatry, psychology, social work. So you have a lot of missing data actually in the development of software. And particularly for the use case of inpatient, I would say it's almost nearly absent. So with that, I'll let Dr. Justin Baker kick us off with some of his work on wearables for inpatient.
So nice to see everybody here. So again, I'm Justin Baker. I'm an associate professor at Harvard Medical School and the co-director of the Institute for Technology and Psychiatry. And I'll be talking about wearables for inpatient sleep and activity tracking, and a study that we've been doing over the past several years that kind of takes us from the bench to the bedside. So we believe that inpatient services have many opportunities for integrating data, particularly wearable data, into clinical practice. And the ones I'll focus on today are really replacing some cumbersome and inaccurate ways of doing sleep tracking that are actually pain points for both staff as well as patients. And then also I'll talk about ways that we can use wearable data to study the effects of interventions on movement and sleep. And we'll be talking a little bit about this idea that, although we can show that there's maybe improvements to the standard of care, the effort to learn and integrate new technology is a real barrier. And so we have to show that the value to clinicians and patients is more than simply the effort to learn and integrate that new technology. So I want to highlight my team who's helped with this work, a number of researchers, as well as clinicians, as well as nursing and trainees. So over the past several years, we've been using a wearable, this particular device I'm showing on the left side, which is called the Gene Active Watch, on a number of psychiatric inpatient units at McLean Hospital. The device is relatively simple. It records tracheal accelerometry, but it has a very long battery life, so we can put it on patients at the beginning of admission, and we don't have to take it off until they get discharged. And then what we can do is compare data directly from the accelerometer with data that we can pull from the medical record to be able to make links between behavior and treatments. And so then we've developed some methods to take the raw accelerometry signals, which is sort of represented in the black here, and convert those into activity scores, and ultimately determine periods of wakefulness and sleep from a scaled and somewhat personalized measure of people's activity. So that open source code is something that is available if anyone else is trying to use more research type devices. And then once we have that, we can then generate representations across an entire hospitalization that I'll talk more about. But here's an example of somebody who was followed for about 3 weeks of a hospitalization. And you can see this is the sort of raw level of data here at the top. And then we can binarize that to get the sleep variable, or the sleep periods throughout the hospitalization. So in this example, this person was sleeping for a very short period of time, and then their sleep normalized towards the end of the hospitalization. But here's, again, to get back to Michelle's point, we really wanted to take a design-centered approach to thinking about how we would use these data in practice. And so the question became, if you're going to begin to record these signals, what results do you actually show? When in the treatment process do you actually show them? Also, who do you give them to? Is it just the patient, or do you give it to the provider, or do you give it to both of them? How much interpretation do you want to place on the data? Do you want to just present them as, here's what the data are showing, or do you want to actually try to make some inferences from that about maybe underlying diagnoses? Also, how much or little granularity is actually useful for the clinician and the patient? And then crucially, what do you do when someone's subjective report doesn't match what the data is showing? So if a patient is saying that they're sleeping a lot and the data is showing that they're not, or what often happens is vice versa, patient feels like they're not sleeping at all and the device is showing that they're actually getting perfectly good sleep. How do you deal with that? What's the protocol around relating that back and using it as a conversation? And so we really wanted to use this design-centered circle where we really empathize with the stakeholders at each stage about what is the problem we're trying to solve, and then ideating, prototyping, and then testing that to get something that would ultimately be useful in practice. And so where we started was what's being done today on our inpatient units, which is very much something like what you see on the right, which is a paper and pencil. Somebody walks around with a notepad and they basically say for each client how much sleep they had and whether they were awake during the night or at each 15-minute interval. And you don't have to read what's on the left. I'm sure it's too small to read, but the idea is that, they have this protocol that they're supposed to follow where they observe the person breathing, and that's how they are able to note whether they were asleep or awake. And it's fairly burdensome, both for the providers, but as you'll hear about later, it's also quite annoying for the patients. They're trying to get sleep. Sleep is a protective factor against things like suicidality and mental health problems, and yet we're interrupting patients' sleep just to document that they are asleep, which is really kind of ludicrous. And so what we wanted to do is, and this is now jumping ahead a lot of iterative steps, but we decided to create what we think of as like a radiology-style report for summarizing behavior. And the reason we got to here is that, as I'll show you in a moment, we did design the version of the X-ray itself, sort of the visualization of the data that shows how sleep is changing and all of the actual measured quantities. And we did that with clinicians, with MDs who were going to be using those data. But when the rubber hit the road and they were trying to use those in practice, they said, you know what, this colorful graph, it's just sort of too much for me to digest. I need something that puts this into words that I can quickly see what the summary is. And so what we have here, again, the text might be hard to read, but the idea is that we provide similar, this is very much designed like a radiology X-ray report would be, where we provide some technical details about, the measurement interval and what kind of device was used, what kind of analysis was performed on it. And then we provide a key summary, or a summary of the key features, and we do that with normalization. So we actually use population-level norms to provide some information about whether this value is abnormal or normal. Then in the sort of fine print is what we call the findings. This is essentially the changes over time in those key features. And then finally at the bottom, and this is what the most busy clinicians might skip down to if they're trying to read an X-ray or another kind of report, is the impression. So sleep in this 22-year-old male shows significantly longer average duration with sleep quality that was about average and onset-offset times normal range. Waking activity was much less than average for this age group. So this is meant to be a lay-friendly summary of the key findings that if you're trying to make a quick decision clinically that you could just skip down to. So then moving on to the kind of more X-ray, the actual sort of the deeper dive, what we provide is an average of the key features. So these are these kind of big numbers which give you the three values: the sleep duration, sleep fragmentation, and the average waking activity. We provide the raw value as well as the percentile. And in this case, the percentiles are based on population norms from the UK Biobank, and I'll show you a little bit more about that in a moment, with the caveat that UK Biobank only studied individuals 45 and up, so For individuals who are younger than that, we end up using the 45 and up age range. Just as a quick sidebar, I'll mention that we did do a study mining the UK Biobank for population level norms, and this is work that's currently in press. And so this used 70,000 examples of very similar actigraphy data to derive norms, population level norms of a week's worth of actigraphy. And from that, we can see a number of things. This is just one set of findings, which is that as you age, your waking activity, the amount of activity you're showing while you're awake, decreases in an almost linear way. But interestingly, when you're depressed, you're actually moving a little bit less, as if you're about 5 years older than your current self. And so these are the kinds of data that allowed us to provide the kind of norms that we provide for the clinicians. So then in addition to these, we also provide sort of like a lab value style summary. So we provide results as well as percentiles and the reference ranges over time, so that you can see as a clinician, how are these measured quantities changing over time in this particular client. And then we have visual representations of the data. So this is changes over time at the daily level for each of these values that's color-coded. But then critically, for linking those data with treatment data, we can pull in data from Epic, from the electronic health record, to see exactly which medications someone was receiving on each day of the hospitalization, along with the doses. And here, we're also highlighting when doses were increased or decreased, so that a clinician, even a busy clinician, could take a quick snapshot and see over what was the titration up and down over the course of hospitalization for this patient. And then if you want to get really granular, you can see exactly what time each medication was provided. So if you're trying to start a sleep medicine or something like that, or finding that someone's getting too sedated on their Seroquel, you might be able to actually see when it was being dosed and maybe adjust the dosing based on the pattern. And then finally, for clinicians who are trying to get a sort of reality check, you can see the raw data there as well. So if there's like naps or other things that weren't identified by the algorithm, you'd be able to see that and sort of check that you believe what you're seeing in the kind of higher level summary. Because I think, again, this kind of approach really does rely on clinicians building trust in the visualizations. So this is essentially what clinicians would receive, is these kind of radiology style 2-page reports, modeled after what you might receive in the old school like x-rays. And so then I'm just going to show you a couple of real world examples. So here's an example of someone who was essentially, the impression was within normal limits. So their sleep duration, fragmentation, and waking activity is all within the percentiles set by the reference ranges. You can see that they're receiving a bunch of psychiatric medications here, but kind of a typical inpatient hospitalization. You can see what a typical sleep-wake pattern looks like down on the lower left. Here's a different example now of somebody who had elevated sleep fragmentation. So you can sort of start to appreciate that in the color graph at the bottom, where it's not as clean as you saw in the first example. There's a lot more green, which indicates higher levels of activity during sleep. And you can also see in the medications, if you squint, I guess, that they're starting to get propofol here. That's an indication that they're getting ECT. And so again, this is more just something that a clinician could use to think about whether they might want to adjust the ECT or the medications throughout the hospitalization. Here's another real-world example of someone who was at very low waking activity, consistent with that sort of high level of depression that I showed from the UK Biobank, and where they're getting just a tremendous amount of medications. I think for clinicians in the audience, you've certainly seen cases like that, somebody who comes in on just dozens of medicines, and you're trying to simplify the regimen to see if you can clean up both their sleep as well as their mental health condition. And you can see in that case what a mess this looks like compared with some of the other examples in terms of not just their sleeping activity, but also their daily activity, their very low activity during the day. And then finally, here's another example of somebody who has very low waking activity and elevated sleep duration. And you can also see they're getting a ton of nicotine during the day and other features here of the case. So these are just some examples to show you how we're starting to use this. We did do a clinical QI project with this, so we're not just doing this for research. We have this as the standard of practice on one of our inpatient units. So it's a little bit outdated now, but between August and December of last year, 155 patients were admitted to this unit. We had some challenges getting people to put the watch on them. So nursing or the mental health specialist would be responsible for, when someone was admitted, putting the watch on the patient. And when they would do that, there was a number of cases where, if either fell through the cracks or the staff didn't feel like it was a priority. And so, just over half of the patients who were admitted did get the watch put on. And then of those, most of them did accept the watch. There was definitely some people who declined the watch. The most common reason for decline was concerns about data privacy, wondering what was being collected on the watch, wondering if it was something that was going to be shared. Other people, there was different reactions sort of related to, well, I want to focus on my clinical care, or I want to focus on discharge, things like that, that even though we were framing it as, well, this is going to be important to your clinical team as part of your care, there was still a sense that it was like an extra thing, and that might be partly that the staff themselves were still new to this practice. But at the end, we had 42 patients who ended up getting the reports and about 80 reports that were generated. So we feel like it was a moderately successful quality improvement project. We're still continuing to use this on the unit, but outside of the QI project. So in addition to collecting the data, we're doing a lot of qualitative interviews. So as Michelle mentioned, we're very interested in the perspective not just of psychiatrists, but also of nursing and of social workers and of all the staff on the unit. And so we have a number of questions in there about, how important is sleep and activity tracking to your clinical decision making? And then also, what are the pain points of the current system, and then what are the sort of things you might want to see? And then we would show each person one of these reports and get their impressions of what was useful and not useful. And so then in the last few minutes, I just want to highlight some other things we can begin to use the data for. So as I mentioned, we're very interested in using the combination of the sleep or the activity reports with medication data to see if we can do sort of pragmatic trials with these combination of data. And so we can basically take movement profiles on days where a patient received a medicine and compare it to days the patient didn't receive a medicine for the same patient. And then we can start to compare and actually assess how a particular medication changed movement patterns or changed sleep. And so we focus for this initial exploration on the benzodiazepines, because those are the most commonly prescribed PRN or as needed medication on our unit. And so we looked at these 4 commonly used benzodiazepines, and what you can sort of appreciate here, if you're used to thinking about Klonopin and Ativan, is that the effects on movement, what we've done here is align all of the movement profiles to when the patient received a medication. And you can see that basically what this shows that the Klonopin it has a longer acting suppression of movement, which is consistent with what we know about the pharmacokinetics of Klonopin, a little bit less so for lorazepam, and then less so for the other 2 benzodiazepines. The other thing we've looked at here is the effect of a next night of sleep. So when you receive the medication in the evening for sleep, ostensibly, how does it actually affect sleep? We talk about these as maybe sleep aids, but how actually does this affect patients? And so we did a Bayesian analysis of basically looking at how does each of these medications change the sleep duration, sleep fragmentation, and other things. And I'll just zoom in here for those of you who are not used to looking at Bayesian results. What this shows is that lorazepam actually was unable to change sleep fragmentation, meaning that the mean overlaps with 0, whereas with Clonopin and clonazepam did shift sleep to be less fragmented in those who were taking it. So I find this to be an interesting use case, because now you can imagine, this was only with several hundred administrations of these medications, but as these methods of using sleep tracking become more common, we can actually begin to use these across many more medication classes and begin to get real-world data in how these medications and potentially other therapies are affecting sleep and activity. So just to wrap up, again, I think that we think that inpatient services have many opportunities for integrating wearable data. They can replace cumbersome and inaccurate sleep tracking, but also they have the potential to study the effects of interventions both at the individual patient, so like we're kind of doing already with the limited sample we have, is seeing if we can use this to adjust patients' medications or other things while they're still hospitalized, but also to do clinical QI projects like the one I mentioned at the level of a service. But then as these methods get more widespread and adopted, we can potentially use these at the healthcare system or even the population level. There's still many challenges. We don't have population level norms for those under 45 yet, although we're working on that. And then again, the value to clinicians has to be above and beyond the current standard of care, because even if there is a benefit overall to them, there's some amount of time it takes and effort to change what their practices are day to day. So with that, I'm going to wrap up and happy to take questions or just pass it on to the next presenter. Thanks. Yeah, do you mind just using the mic?
Thank you for that presentation. Very interesting work that you're leading with, I believe, a number of folks. One of the rationale for doing it was that the sleep assessments, as they're often done, are very disruptive and counterintuitive to what we're trying to do. And so there are other reasons, though, often why those checks are in place. Often many patients are in Q15s. There's safety considerations, yes, sure. Checking for breathing. So, is your vision to eliminate some of that, and how do you replace the other things that are done?
Yeah, great question, and you're going to hear more about that, I think, from some of the next presentations. But we initially, I didn't say about some of the things we decided not to do. So when we first started this work, the idea was we could use wearables to detect when patients are getting agitated and have that be like a real-time signal back to the nursing staff. We decided to hold off against that because, for one thing, it was a more challenging use case. We needed a device that could operate in real time and things like that. We decided to go with sleep tracking specifically because it was a quantitative measure that staff knew they weren't very good at, and it wasn't as clear that the current method was providing sufficient level of detail. Of course, there are other reasons people get checks, like for safety, right? And I think, at least in our use case, they would be we would continue doing this concurrently with safety checks. But I think, as you'll hear about, there are potentially ways to do that with the wearable solution. So I'll leave that to Michelle to get more into. Yeah.
And maybe you can just repeat it.
Yeah.
So how come gene active versus, say, some of the commercially available Fitbit? So I feel like we're seeing more Fitbit and Oura Ring.
Yeah, I'm wearing an Oura Ring now. So the rationale was twofold. One was the battery life challenge. We wanted a device that, because we also started using the Embrace 2, which is a commercially available, still kind of more research focused, but it had a shorter battery life. It had a wireless capability, but a lot of the commercially available devices like Fitbit and Oura Ring don't provide raw data. Now Fitbit, I think, is changing that to some extent, but it's still something where we were concerned about open science, but also thinking about downstream if we were to collect population or data across the whole healthcare system. We wanted more than step count. We wanted to be able to see the full range of movement patterns that would be affected by medications. And so we were really geared towards devices where we could get that raw accelerometry signal. So there are more devices around now than when we started, and we're still open to changes. But the price point, the battery life, and the access to raw data were the main reasons. Yeah. Yeah, Andrew.
Justin, such great work. Can you say something about the response from nursing and medical leadership on the units? Because obviously I'm biased, I'm here, but it strikes me as such useful data for them. But we also know that sometimes people can be conservative and threatened by new data sources. And I'm curious what the response was on the units where this was deployed.
Yeah, so I think in general, leadership on the units are always favorable. So we work directly with the medical director of the unit and the nurse manager on the unit. Both of those folks were absolutely, we should be measuring this much more reliably every day, and so on. And I think that the staff, we did we tried to get buy-in from them by having in-services throughout the project and helping them realize how this could be useful. But I think there was still a question of but useful for what? As we did the QI project, there were definitely cases where the regular operating staff realized that a difficult case could be aided with this. So the one anecdote I mentioned was a patient who had been there for weeks who was saying that they were getting really poor sleep, and the staff were like, no, we don't think that's accurate. And so they opted to have this kind of sleep tracking, and that ultimately did help the patient get discharged and so on. So I think they're more and more interested as they get exposed to the technology, but I think it's a challenge. It's that rolling the ball upwards so that it can go down further. It's they're still a little bit skeptical about how is this going to change my day-to-day activities, and is it really leading to better care, or is it just yet another thing we have to do? So, yeah. Great. All right. Well, I will pass it on to the next presenter. Thanks.
Okay. I think that last question is a perfect segue into my presentation. My name is Marie Fletcher, and I am currently getting my PhD in nursing research at UTHealth Cizik School of Nursing. I had the privilege of working with Dr. Patriquin at Menninger together, and so a little bit about my background is that I did work in inpatient psychiatry, and then I kind of moved into the neuromodulation space, and then from there I became a clinical staff leader who was supervising both inpatient and more of this outpatient population to kind of see attitudes towards new technologies was really informative, sometimes challenging, but now I have started working with my faculty advisor who really works on workforce, so specifically looking at nurses and how we can best support them so that we can be excited about these new technologies. And in order to do that, I'm going to take a look at implementation science and then the workforce that I work with, which is psychiatric mental health nurses, and then a really close look at the work environment or inpatient psychiatric setting, because I think, as we all know, that's really different than outpatient land. So I guess a little bit cheesy, but implementation science, what is it and why should I care? Dr. Jukic shared this article with Dr. Patriquin and I think it really, I thought I knew what implementation science was, and that sounds helpful, but really doing a deep delve, any show of hands, familiarity with implementation science and the frameworks that we use. Okay, great. So some familiarity. I'm going to talk more about the consolidated framework for implementation research, which is the CFIR, and how I think if we were kind of gathering data in this way, it would be a really helpful way to share it across the country and across different programs. But still today, even though evidence-based medicine came about around 1992, we're seeing that studies take 17 to 20 years to get clinical innovations into general usage, and fewer than 50% of those clinical innovations make it into general usage. And so really it becomes this question of public health. How do we get what we know what works to the people that it would benefit most? And so within implementation science, you can start to do a really deep delve, and there's Nielsen's taxonomy of what might be most helpful, but for the purpose of this, I really think the CFIR could serve us well to kind of make it so that we can all understand what we're doing and be able to share information. A little bit of a difference between clinical research and implementation research. So this idea that figuring out what works and then handing it off to the implementation science to test the way to get it to the people most effectively, it's a little bit oversimplistic, but it helps me really conceptualize the differences. And then I think the most helpful thing, especially for this, is understanding that non-adoption happens a lot of times because of the professional disciplines that we're the intended recipients or the ones that we're handing it off to. Are we depending on these nurses to get the wearables onto the patients? And do they have an appropriate understanding of what the benefit is? But before we ask those questions, I think it's really helpful just to kind of do an overview of what the psychiatric mental health nurse workforce looks like. There was a really helpful survey that was done between October 2020 and February of 2021, just getting a lot of demographic information about psychiatric nurses. And we know that about 89% of RNs in the psychiatric discipline do work in inpatient hospitals, which is a very high percentage for a discipline of nurses. So when we're making these overall statements, it really does pertain to the majority of them. And so, one of the most recent studies shows that as high as 84% of psychiatric RNs are reporting workplace violence. And that's a very high percentage when compared to colleagues on medical surgical units. It's about, it goes up and down with emergency departments, but I think as we ask nurses to take on additional roles, really understanding, are they feeling safe at work, and how are we contributing to that so that we can ask them to take on new things. In a nursing workforce survey, over 200,000 RNs have left since COVID, and then this really astonishing statistic that about 25% of them plan to leave or retire, and 60% of them feel like the workload has already increased since the pandemic. And so I think partnering with nurse managers and administration to understand what are the things that we're asking of them, and how are we making sure that it's a supportive environment, because being excited about something takes feeling safe and supported. And so I think really looking at that, I've done a lot of research over the past semester on workplace violence. And maybe this idea of, a wearable for a nurse to be able to track when are these occurrences happening, how can we make sure that we're tracking them accurately. Another really concerning statistic is only 20 to 60% of workplace incidents are being recorded or reported. And so if they're not being reported and these are so high, then what are they actually? And so, I think I can speak for myself as a nurse. Technologically, I'm not the most advanced, but getting excited about how can we use this kind of technology to support the provider with the most direct care hours with the patient. And so really exciting that my faculty supervisor is thinking about that, and then also weighing, it's this constant balance of not putting the onus on the individual and really asking the organization and then administrative to support how can we be tracking this data so that we can know how to best support them. And then I think we're all familiar with the inpatient psychiatric setting, but another really concerning review revealed that the highest levels of workplace violence are happening on these psychiatric units. And so when we think about, I think this is the main topic of the talk, which is super exciting, but we're truly co-producing with the patients and the providers, so that when we do drop in this new exciting technology, everyone feels like they've been a part of not just like this is what we're doing, but how does it make the most sense to do this? If you are providing in-services, a lot of times those aren't protected hours, and so asking, how can I best phrase this? Who's paying for the training? Are we writing a new nursing policy? As antiquated as that is still the way that nursing does it, and so we want to be able to refer back to this policy of the best way to teach this so that when I'm going off of my shift, the person behind me understands it. And then when you start to really think about what a high turnover there is in nursing, so what's at the forefront of what's being taught so that the innovation is sticky and it doesn't depend on the individual. It really depends on the entire inner settings, excitement, and dedication to it. So a little quick look at the CFIR. I don't know if we're familiar with this. It was new and exciting to me this semester, but it was published in 2009 and then revised in 2022. I think it's really helpful because it can be used pre-implementation, during the implementation, or afterwards to really do a data analysis of what went wrong, what went great, what could we do better, and really conceptualizing it as a map to move forward. So this is can you all see that? Maybe it needs to be a little bit bigger. But just a really quick, in this case, we'll use the wearable, so that would be the thing, right? I gave this presentation last week on ECT, so you can really use it for different. And so when you think about ECT being the thing, you're thinking about all of these different, teams coordinating together, obviously. The adaptability, the trialability, all of these things differ depending on what the innovation or the implementation is. And then on the forefront, really thinking about the implementation process, training, assessing needs. Again, as antiquated as it sounds, are the nurses still paper charting? Is this the first digital intervention that you're introducing? And being able to have like an honest conversation about that. And so then the outer setting really depends on where you're introducing this. So I can imagine that it looks different on the East Coast than in Texas. But I'm sure that there are some things that overlap. In terms of ECT, the outer setting looks really different because state-to-state laws differ. I'm not as familiar with Q15 checks, if that's a Joint Commission standard. I think there were conversations with the Texas state about, actually, that might not be what we've said, but that's how it's been interpreted. So those kind of conversations, this kind of map makes it really easy to say, this is what's going on here, this is how we can apply it there. The inner setting is the organization itself. So are people generally excited about new departments and new developments? And, I think we can all wish that yes is the answer, but sometimes that's not a resounding yes from everyone. So understanding when was something recently introduced, what went well, what didn't, is it compatible with the current workflow? And if it's not, acknowledging that on the forefront so that there can be conversations about how leadership can best support it. And then the individuals themselves, who are we asking to really implement this innovation? One paper I recently read was talking about how they found that if there was a champion in administration, so that there could be this continual conversation, we're coming back to this, how can we make sure that, the nurses are feeling supported? And the fact that it was a nurse and the administration really panned out well, even though the innovation itself was coming from majority MDs. And so, I think as we continue to do these really exciting technologies and innovations, if we can maybe have this like standardized map so that we can share it and it can spread in a successful way. So I think we all know there's a cost to not involving all stakeholders, ideally at the start of the innovation. And so if we can continue to utilize implementation science, especially the CFIR, we could have really amazing outcomes. And that is my contact information. Yeah.
Thanks, Such a great presentation, and it's so exciting to see a framework for this because I think, just as you were saying, I experienced that it's a lot of anxiety, a lot of confusion when we implement new things, and to have a framework makes so much sense, and to have it led by nurses also. I wanted to ask you about staffing because when we talk to our nurses, I think the number one thing that they worry about is workplace violence. Mm-hmm. But then the solution for them, the only solution I think that they've seen to be effective is just to have more staffing. And my hypothesis would be that one of the anxieties, whether voiced or not, is are you going to use this to try to get away with lower staffing? And I wonder if people say that, or if you've heard anybody say that, or how do you talk about making sure there's adequate staffing, which we know in most psychiatric hospitals it has been a tough issue over the last few years for reasons you described.
Yeah, absolutely. I think it sounds like you're doing a great job just by acknowledging that that's a top concern, right? Because when we start to think about and speak to nurses who have been assaulted or verbally threatened, they're focusing on getting through their shift safely, not on what new kind of things are we excited about. And I think there is legislation being passed. I will say, Texas, we don't lead the charge in much. I shouldn't say that, but we just passed legislation. It's called the SB 240, and it's about workplace violence and kind of the committees and the reporting that's mandated by the state. There's federal legislation about that, and so I would say to nurses like, okay, you're concerned about this. What can we do to support you to understand what's going on at a national scale so that you are getting, because what ends up happening from that is hospitals get more funding and then staffing becomes less of an issue. Or a certain kind of staffing gets brought in that maybe could maintain the safety in a different way so that nurses can focus on a more direct patient care. And so it's definitely a complicated issue, but I think just listening and understanding that is a lot more than a lot of people are doing, and so I think that's probably a really helpful start. Okay.
Hello everyone, so I'm glad to be here. I'm Dr. Manuel Soulard. I'm from McGill University, currently a PGY2 in psychiatry, working with McPsych Lab and Dr. Ben Rimo, who's my PI. So we've been asked to kind of talk about one of the projects that we're currently working on and how we kind of use human-centered design through it. So there's a bit of a plan. We'll talk about the DeepD project, which is the main project I'm working on. The process of creating return of results reports of patient, some results from the literature that kind of are the basis for that, some report examples that we're currently using and giving to patients, and a clinical example of all of that. So to start, what is DeepD? It is mainly it's called deep phenotyping at the Douglas, which is the hospital where we're working at, the Douglas Institute in Montreal, which is this mental health institute. The basis of the project is because of, as you know, the lack of blood and biomarkers, which are usually practically used in other practice of medicine to monitor, stage, or predict the course of patient. We don't have that in mental health as much. Right? There's a lack of comprehensive measures, and most of our gold standard, let's say for depression, are standardized rating scales that we kind of use to diagnose. They're widely used for major depression, but there's some practical challenges that comes with them. You can think of just the physician burden of increased workload to complete scales, or overall severe mental illnesses like schizophrenia that makes self-reporting scales more difficult to use. So all that kind of comes into account. So kind of in response to that, and with the rise of digital biomarkers in mental health, decided to try to use these technology to create this phenotype profile of patients, try to see if we could gather data from them that's helpful to understand the evolution and symptoms of their illnesses. Again, it's driven by increasing availability of digital technologies. We're talking smartphones, smartwatches that everyone has and are tracked actually in the day-to-day. So we're thinking if Apple can track us, why not we? Eh? So some of the potential of digital biomarkers, we can use the sensors as Dr. Baker told us about, carried by the patient to derive markers of interest, can offer continuous real-time data collection, and hopefully they may support monitoring, staging, and predicting mental health conditions. So the objectives were to identify and validate the most effective digital phenotyping technologies that work across different diagnostic categories. So currently we're working mainly with first episode psychosis patients, so younger patient type, but we're enrolling patients through trans diagnostic categories. The goal is also to use them like in this field testing real world setting and refine these technologies output into a robust set of measures and reports, and to establish a reliable foundation of measures that can be rigorously tested in subsequent clinical trials, more a feasibility study at the moment. So interestingly, there's a part of the study that will eventually come to inpatient, but at the moment, most of the enrollment were from the outpatient clinic, so the first episode or the mood and anxiety disorder clinic at the Douglas. Hopefully after Christmas, we'll be able to enroll some of the patients and we'll start to get data from the inpatient setting, which will be interesting. The monitoring duration is from 6 months to 2 years, where we collect a wide range of observable measures using digital and also non-digital tools. So we still use self-reported questionnaires and clinician-rated questionnaires for patient. And I think most interestingly is the field testing part where we collaborate with clinicians, patients, and it's not written here, but also caretakers to kind of use report formats that we give back to them. And as part of this iterative process, kind of modify them to see if they can help kind of engage the patients, their caretakers, and physician in the care. So some of the key metrics that we're using in DeepD at the moment, and that's why it's in bold here, it's mainly the actigraphy watches. So we only just started in the beginning of September. So we've been using, basically I'll just go here, it's the same watch that Dr. Baker has been using for the same reasons. Basically it's we're seeing these patients every month, so it's for the battery life and the fact that it's raw data and it's very sturdy. Very resistant also. So that's the main one we've been using for sleep, GPS tracking position, displacement, mainly daily activities. What's coming in the 2025 is we have a team working on our phone app called MindLamp, which will be looking into phone activations, incoming, outgoing call and text, metadata, engagement with social contacts, use of social media also. So that will be interesting to see. And we'll have, through the phones, what we call EMAs, so ecological momentary assessments, which are kind of like notification that will pop up with either some digital cognitive assessments, a mood assessment, very short that a patient can answer quickly on their phone. And again, there are patient reports and clinician report questionnaires that are ongoing. So again, that's the main watch. I will say we've been working with mainly like the youth, like the young patients, and the main issue with that watch was that it's not super fashionable. So this kind of, besides that, it's been well tolerated with patients, but it was that it doesn't really look like a watch. So the part I'm a little more involved in right now is the creating return of results reports to these patients. So a little bit is the design iteratively based on clinician, patient, and family member caregiver feedback to summarize all that collected data that we're currently getting and putting it in a report form. Hopefully will help facilitate clinical decision making and patient self-management. And once finalized, we kind of have a good example of that report that will be used in future prospective clinical trials. And we really hope it will be a major driver of patient, caregiver, and clinician engagement. We do know that this population is often, it's difficult to kind of engage them in their care. So hopefully it will be a tool to discuss that with them. So it's been based mainly on this. I've been researching some databases just to kind of know if there was some, already some knowledge about how to give back data, visualize data to a patient and physician and caretakers. There was about 25 kind of papers that were very interesting towards that, and 5 that were more foundational that kind of led to the creation of our first mock reports and eventually to the current version that we're using for the reports. The results have been that there is still significant gap that remain in the literature regarding the presentation of symptoms and broader collected data to patient, providers, and especially caregivers. I think that was the main point. There was some from like our other colleagues in like diabetes management, genomics, surgery, and pain management that had some interesting findings on how to kind of give back data to them. But to involve caregivers there was not a whole lot on it, so it will be interesting to see. And most articles provide kind of vague information with limited generalizability due to the small number of studies addressing the topic. So that being said, there were, from the 5 relevant articles, there were 2 systematic reviews that were identified to kind of guide the drafting of the initial mock report. Most of the kind of key points that were exported from that design principles and overall patient understanding is that simple graph dominates successful implementation. So that's kind of been based in like evidence-based. when you use line graphs, it's best for tracking kind of changes over time. And bar charts have the highest comprehension rate for like static data, if you will. The key success for factors which are important to give back that data is to focus on accessibility and clarity and to use consistent format use. So the font, color coding, and placement of objects in a report are really important and has been shown. And also to integrate familiar visual elements to patient to kind of engage them. So the reports themselves, the first version that we had were presented to the design committee that we are lucky enough to have, which is made up of psychiatrists, patient partners, and caretakers. So they help us kind of guide the project itself, the DeepD project, but also the reports and give their impressions on it. Feedback was gathered on design, functionality, and usefulness. We also had patient feedback. So of the first batches of reports that I'll show you in just a second, we were able to have input from 5 patients that have enough data. So again, we're currently we have like 15 patients enrolled at the moment and still enrolling. But from the ones that had enough data, there were 5 that we were able to do reports to them. And so far, the feedback has been very positive. They really liked to be able to track their symptom, to be able to discuss that with their doctor, and just the overall design of it was positive, which is very encouraging for us. The next step is that second version based on the feedback we'll be rolling out next week, actually, when we will be giving out this new version. And a physician version will be expected around January 2025, which I'm currently working on. And at some point, a little later, will be the caretaker one. So we'll have like 3 different versions. Okay, so that's kind of the first mock version. So that's not real patient data. It was just made to kind of as a placeholder to show you the evolution of the reports over time. So you can see that it's mainly graph-based, right? And that's more the patient version. So it was always the difficulty was to decide how many data do we provide, a little bit how do we interpret it, like Dr. Baker said, that's always part of the issue that we're having. How much data do patients actually want on there, and do they find it useful, do they find it difficult to interpret? And also all the little like blurbs or definitions, they have to be simple enough for patient. Based on that, that was the first version that we kind of made here. It's a 2-pager. So the first page kind of shows some of the graphs that we made through Python with the actigraphy data. The one on the, actually I do have the little, yeah, okay. I don't know if it's shown here. Anyway, on the left here is the sleep kind of data. So it's very small, as you can see, and the patient receive it on paper form. So the goal is eventually to bring it to PDF, because that's the medium I'm using, but for now, the first patient received it in paper. So they were able to see, but as you can see, like some of the sleep data that are kind of the sleep mean rise, mean sleep onset, and all of that is very small. So that was one of the feedback that we've gotten. Also, some of the blurbs were a little too complex and used the name of the scales that they've been, well, actually, just more on the outcome side here. But so they find it a little more complex to use. The reports themselves are kind of split between call of action, which is mainly the actigraphy data, and at some point when we'll have it, the phone app data that we'll also have. And on the other side here is more like the outcome data that we call, but it's mainly the symptoms of the patient using self-reported questionnaires. So we have one from the PHQ-9, the GAD-7 for the moment that track their mood and anxiety. We're using the SAP-SANS also for the psychotic symptoms of some of our patients with general symptoms here, so hallucinations, negative symptoms, delusions, whatnot, and at the bottom is the total score. We're also using the CGI just to give since it's only the first version, kind of give a good idea of just their overall functioning for patient. They really like the fact that we're using color coding here to kind of see if they're in a higher range, more like severe or milder range. That was liked a lot by patient, but they felt like, again, the data was a little too small. For SAP-SAN, it was a little too crowded. We can't really see it very well. Also here, we only had that one data point, so that's why it's not tracking. So we made some changes. An interesting part is just the monthly recommendation here, depending on what changes in the reports. It's kind of, again, to help engage those patients a little more. And on the verso, I guess, here is their data from actigraphy tracking since the beginning of the study. So it's to give kind of an idea of their overall progression since being enrolled here. And it's in graph form with sleep efficiency here being used like the one on the right here. Can I switch here? Give me a second here. Okay. So the second version here, from the feedback that we gather, we kind of had to make a compromise and split the data from call to action and outcome to a two-pager. So it's given to patient, again, in paper form, so recto verso, again, so they have the call to action on the first page and the outcomes ones on the other. So they can have these kind of one pager again, but just a little more exploded, if you will. It makes it so the graphs themselves are way easier to see. And also some of the information were kind of put out and put in more in like bigger tables for them to kind of see and assess with, again, a little bit of jargon and category, but there's a third page that's optional, but that's always there just to help with definitions to, again, try to help with patient understanding. This is the one version we presented to the design committee a couple days ago. They really liked those changes, and we'll see how the patient react to them too. Because it's kind of the same information, but just using different formats. And I just want to highlight that the icons were one of the things that the patient really liked too. Just the category icons were engaging for them. One of the main changes from this to the second version too was mainly the psychotic symptoms. You can see we switched from this graph format to more of a kind of box, well, table format with interpretation of severity, because they felt like they had difficulty understanding what it meant without clinician explanation, and that was a little simpler. So again, kind of iteratively using their feedback to create it. And we added substance use because they felt especially the caretakers felt it would be an interesting some interesting data to have from some of their questionnaires that they're answering, and again, the functional impact with the WHODAS, just to see if it's relevant data that they're using. So trying things and see how they respond to it. And that's kind of this third optional page where you can see how kind of the ranges of severity for the different scales there. So it's kind of soft interpretation in the sense that how do we interpret raw data? With the first version was kind of very raw, and they felt like they didn't quite understand. Maybe for physician it would be more pertinent with just using raw data, but for patient they needed a little more interpretation for that. So just as a quick example here, it has already seen to be clinically useful. That's the graph for sleep and sleep efficiency for one of the patients that we've started to enroll. We got the data after he came to the clinic to give back his watch. And also that's kind of the moment where we assess them usually. And he unfortunately was found to be a lot more psychotic, a lot more unwell at the moment, had to be redirected to the emergency room at that point. And when we got the data, we can kind of see that the couple of days prior to that decompensation, there was a clear decrease in sleep here and also sleep efficiency. So it's still very preliminary, but it was kind of interesting to see kind of this pattern that we're already emerging for patient here. So in conclusion, deep phenotyping shows promise in transforming psychiatric care. Overcoming current challenges will require refining device accuracy, usability, clinical integration to fully harness their potential in real-world practice. Promising tolerability of devices so far, again, it has been very well used by the patient, and also positive feedback on report creation that highlights potential for continued refinement and usefulness in human-centered care. Thank you.
Love the talk. I saw in one of the slides you had like for baselining. Mm-hmm. How long would it take to get a reliable baseline for an individual to say whether something actually changed from that or not?
Right. So the baseline one I think you're referring to is the one for the WHODAS that we're doing at baseline here. It's a very new addition to the report, and at the moment we only have kind of this, because when we get patients that are enrolled in the study, they go through all of these baseline questionnaires from the clinicians and also self-reported. And thinking with that WHODAS one is they have that baseline functioning, and every month or so they receive the reports, but the HUDAS is done every 6 months. So it will kind of be to see if they improve from baseline or decrease from baseline at that moment. Yeah.
Thank you. Excellent presentation. So Venkat, based at the University of Toronto. So a question about how you've navigated privacy, with wearables, and do you have the data stored in Canada, or did you de-identify data and actually send the data across the border? We've had a few projects where that was a critical issue, so I'm wondering how you've navigated that with your REB.
Yeah, that's a very good question, and we have a couple of discussions around that. Mainly the data is stored on kind of the Microsoft servers. I don't know exactly the specifics, but they're a version of there that are on our servers at the Douglas Institute, and some of the other data are more on the kind of secure, if you will, Microsoft servers that we've been using that were approved, I guess, by the institution. The object of confidentiality when we deal with that data is always kind of a debate, because how safe is it really? It's made very clear for the patient when we enroll them. That's always part of kind of the risk of using that type of data. But so far, it has been going well with it. That's why we've been using it.
I love the emphasis on design. I find that people often deprioritize things as simple as fonts, which make a big difference in terms of visual language. So I love that you focused. I had a question about the use of a static PDF or image versus a dashboard that one could drill down in. I've sort of struggled this with myself, where on the one hand it's more familiar to people to just get a static PDF, but if you can get people to actually click onto a website and then be able to, investigate things in ways that you couldn't put in a static page, it's even better. I'm curious about how you thought about this, or if you're considering anything like that.
Yeah, definitely, and so excellent question. We thought about it. The main issue at the moment is funds, actually, to make that. We have a bit of a team of, we have software engineers working on some of the aspects of our other projects, and eventually the hope is that step one, once we have kind of a stable version of the reports, we'll be able to automatize the creation, because at the moment, since we have only a few patients, it's basically me creating the reports manually. So if we scale up with patients, it's not doable anymore. So we'll be to automatize that for one, and afterwards to transform it in a dashboard fashion. Is part of the goals, definitely. But we're a small team at the moment, and the funds are a little insufficient. All right, thank you.
Manuel, that was a great transition to talking about business. Okay, let's see. So my job today is to talk a little bit about two other perspectives that are often not included in these conversations when we talk a lot about research, which are the lived experience perspective, the patient perspective, which excitingly most of you did include, and then the role of actually getting funding and getting something out there into the real world. So obviously lived experience comes with a story. So I'll start by sharing a little bit about how I got here. I was misdiagnosed at 14 with bipolar disorder. Spent the next 10 years of my life in and out of multiple hospitals, multiple doctors, many different diagnoses and medications, until finally at 24, I found McLean Hospital. They gave me a 2-week intensive assessment process that finally got me the right diagnosis, borderline personality disorder, the right 11-month treatment program, and it saved my life. I went from not being able to leave my room, suicidal, to 6 months after leaving the hospital, I was COO of a successful startup, went from there into investment banking, returned to investment banking, closed over $40 billion of mergers and acquisitions, and luckily was able to leave and start my own company, which is focused on building data ecosystems into the treatment of psychiatry. And most recently have joined Silver Hill as program director of their new New York, Silver Hill, New York program, which is very focused on integrating data into the actual clinical model of treatment of patients. So with that said, there's a lot of solutions at this conference, and I think that's super exciting. But a lot of what the patient and business perspective is to ask, what's the actual problem we're trying to solve? And if we solve it, who's incentivized to pay for the solution to that problem or to fund the payment for the solution to that problem? And so taking both the business and the lived experience perspective, you kind of are like zooming into your own history and then zooming out into the sort of ecosystem of how things get paid for. So I started off by making this little chart, which you may not be able to see too much detail, but this is basically my own treatment history and how much it cost me to get care over the last 20 years. And the number is $1.6 million over 20 years, of which 50%, all the stuff in red, was wasted. It didn't work. And not only did it not work, and just to orient you, this is 2000 to 2024, and you see two peaks, which are the two hospitalizations, and then sort of outpatient treatment outside of that. Not only did it not work, but I think a really important piece of it not working is that that's not neutral to the patient's outcome. Every time that a patient fails treatment, or every time I fail treatment, it made it harder to remotivate myself and get back into treatment. And you start to lose hope and lose motivation and lose it's anti-placebo effect. And the system around me that was trying to treat me became increasingly risk averse, right? Every time that I failed something, or that I even seemed like I was about to fail something, more treatment was thrown at me and more doctors and more medications, to the point where I became a very successful professional patient, which makes it really hard to get back into the real world and build a life worth living. And so zooming back out, why is it so hard to get patients better? And I sort of categorize the answer to that question into three different categories. The first is that we don't understand our patients well enough, and I think this gets to a lot of what we're talking about here with deep phenotyping. We have inaccurate or incomplete assessments of patients. We have inconsistent assessments of patients, that different systems give different diagnoses to the same patient. And we have biased assessments, especially with something like borderline personality disorder. Studies show only 7% of clinicians are willing to give the diagnosis, even if they know that the patient has it, because they're scared of it. Our treatments, even if the assessment's right, the treatments aren't good. There's not enough providers, which has been the focus of a lot of venture capital investment. But even if there is a provider, often they're not really that high quality. They're not delivering care that really works. Or even if it's care that works for someone, it's not care that works for the patient at hand. And then finally, there's sort of these systemic issues, which is if we don't have outcome measurements, we have this lemons problem, as we call it in business, which is that we as patients or payers, insurance companies, don't know who's a good provider, don't know what a good treatment is. And so that makes care hard to justify paying for, especially high quality care. So care becomes unaffordable, not reimbursed at appropriate rates. And why would a patient trust you if they don't know that the care is going to work? And so you have patients who, even if all of the rest of this worked perfectly, don't show up to treatment or don't engage in treatment fully. So yeah, there's a lot of diagnoses, more than I even had when I showed up at McLean. And what I learned at McLean is when you have that many symptoms of a person or a system, usually there's one core underlying fundamental problem at hand that if you fix that, everything else starts to go away. And to me, that's data, and that's why we're all here. So I think the answer is building a learning mental health system, right? It's that right now we have a diagnostic period, a treatment period, and in most cases, there's no reassessment, there's no continuous assessment of the patient, there's no longitudinal learning. And so what we saw in the earlier talks is building that reassessment, building that continuous learning process so that we can actually know if a treatment works or doesn't work before, during, and after a patient is going through it. And in my mind, if we could fix that problem, that actually makes a lot of the systemic problems start to resolve, because we can actually identify what the quality treatments are, pay differentially for quality, retain providers that are delivering high quality and not have an adverse selection problem, and patients will start to trust that the treatments we're delivering actually work. So that's all obvious. We're all here in this room probably because we all believe that already. So why doesn't it exist in reality? And as putting my MBA hat back on, I think the answer is somebody has to pay for it. It's really expensive, like Manuel said. Building these technologies is not cheap. You have to have a huge team of software engineers, data scientists, researchers, clinicians willing to deliver this kind of care. And so what I want to step back and think about is who's actually going to pay for this? And oversimplification, but there's sort of 4 core stakeholders in the mental health system that pay for things. The patients themselves and their families, payers, insurance companies, providers, and pharmaceutical companies. There are others, but those are the big categories. And I think it's really important if you want to get something paid for and want to create a fundable business model that you know what the incentives are in the system for somebody to do something. In my mind, patients want to feel better. Everybody else is a business and they're trying to maximize profits. Whether they're for-profit or non-profit, that's just who the profits go to. But they all have to maximize profits. And so figuring out how to align stakeholder incentives with actual quality outcomes is not trivial. So this is a very basic equation. It's basically profits equals revenue minus costs. Revenue is how much you sell times how much it costs or how much you charge for it. And as we think about the different types of stakeholders, it's easy to try to shoehorn concepts of quality or getting patients better faster into these different categories. You know, you could imagine if you're a really good provider and have high quality outcomes, you can drive more census, or maybe you'll be able to charge more for your services. You can imagine that payers are excited to reduce the payouts that they have for adverse events. But it's not entirely obvious, right? You could also imagine that getting patients better faster could reduce census for a provider. People go through the system faster and exit faster. And similarly, deep phenotyping and better categorization of patients could actually reduce pharmaceutical companies' target markets because you have a much smaller N that's actually going to respond to that medication versus generalized depression that you currently could target now. And so the conclusion that I've come to, which you may see something different here, is that patients are actually the most closely incentivized to have quality in the system if they can figure out that something is high quality, and that's where the data comes into play. And so one of the things in our work at Silver Hill, New York, that we've been really focused on is how do we talk to patients about how deep phenotyping and bringing data into their psychiatry can actually get them to get better faster, and to even know that they're getting better faster. And that conversation really took me back, sort of going back to the small N of 1 for myself of lived experience of trying to reflect, how did I know that my treatment was good when it was good? Had I been collecting data during my recovery, what would it have actually looked like? Would it have aligned with the things that we're designing here in this conference, or would it have been different? And then what's universal for all patients versus what's just my own experience and individual? And so what I'll show on the next slide is just a sketch of, you know, if you had looked at my data over the course of my recovery, what might it have looked like? And you start to see some of the pitfalls, right? So when I entered McLean, I actually probably would have had a lower subjective distress level than when I exited McLean. It was probably 3 years before my distress level went back down below the distress level that I had when I got there. So these clinically validated measures are fine and good, but possibly problematic if we use them alone. Some of the measures that I think would have been most immediately, clearly, obviously changed from my treatment are location measures, which is something that we do at Silver Hill, New York, where we measure how much time somebody spends at home, how much time they spend at specific locations that are meaningful to them. For me, it would have been my work or going to school. And I had a massive truancy issue. And so you would have seen before treatment, basically I wasn't showing up. I was just at home in bed. After treatment, okay, I left my home, I got to work, and I did so consistently over time. And so that's something I think you would have seen as like a very important indicator of recovery. Having BPD, number of fights with my partner, would have been an important indicator of my issues. It pretty quickly dropped off after treatment, but I almost overcorrected, and I stopped being willing to have conflict. And then in the past few years, I've been like, hey, actually maybe conflict could kind of work. And so, there are these measures that maybe are, I think work is another one. I probably overcorrected and worked too much, trying to pull that back a little bit. So thinking about sort of normalization and what are sort of, for the individual, the right norms that we can look for. And then there were measures, the last two I would say are things that, had you asked me in the past, I wouldn't have even thought to think about them as things that mattered to me in my recovery. They weren't on my mind, they didn't matter. But now 10 years out, looking back, I'm like, these are actually probably the most important things to building a life worth living and thriving, right? Being able to define myself, having an identity that's coherent, being able to grieve and process emotions. And so, one of the things that we try to do with our patients is really sit down and say, for you individually, what are these measures that matter, that we could measure, right? Like, is home time going to matter to you? I don't have sleep on here. Maybe sleep is really important for someone else, and really figure out that individualized sort of cohort of things that we expect to change, and do that in collaboration with the patient and the provider. And so the thing I'll say about this, which is the last point, is in order for me to get here without the data, I had to have a psychiatrist who really deep phenotyped me every single session. He had to deeply understand who I was, where I was at, and hold the bar a little bit higher for me every single time, which is awesome. But for those of you that sort of know the New York City psychiatric market, that's extremely expensive. It's cash pay, and it's not available to most people. And one of the big opportunities and big problems I see in the psychiatric market is what I would call the psychiatric frontier. That basically there's two markets that are very distinct. You have private pay artisans that can really do that deep phenotyping work themselves. They don't take insurance, and they're mostly in like concentrated hubs in coastal cities. And then you have these sort of large scale reimbursed providers that don't have the clinicians with the time or the tools or maybe even the training to do that kind of deep phenotyping work themselves. And where I think the problem that we can solve with this deep phenotyping work really lies, and the business model really lies, is in shifting the psychiatric frontier. Being able to take this deep phenotyping and give it to all clinicians, build training models for clinicians of how we can use this to really deeply understand our patients better and deliver sort of the highest quality care at greater scale. So with that, I am done. Thank you all. Any questions?
Lindsay's just so amazing. I mean, the way you tie all these things together, and obviously I'm a fan. So, but I wanted to go back to a slide. I don't know if we can still put it up, but despite the fact we work together, I have never seen that slide you put of your experience.
This one?
With
Oh yeah, this one.
that one. You just passed it.
Yeah.
And what it made me think is what an incredible tool something like this could be to all patients, not just going forward, which of course would be our dream, but even going backwards. And so I wonder if you would say something about what your process was like assembling this slide, and do you think this is something we could do going forward as clinicians with all patients?
Yeah, it's a really good question. I mean, and I don't even know that this is the correct slide, right? But I think thinking about, often the conversation that I have with our patients is like, if we're successful in treatment, what does that look like? What does that look like for you? And what has worked for you in the past? What do you feel are the leading and lagging indicators of times that have been good and times that have been bad, which I'm sure many of you have those conversations. We just tend to say, okay, now let's dataize it. Let's make that into a trackable solution. And so I think it helps it helps with self-discovery in some ways, and I think helps with telling your own story. But it also, I think, helps align us all towards the same mission and facilitate in some ways the conversation around maybe those bottom two, where you're collaborating more with the clinician of, okay, the patient doesn't see the whole picture. The clinician doesn't see the whole picture either, but like, what does the clinician see the patient's trajectory might be, that the patient doesn't see themselves, and how do we do some psychoeducation around what that means and what that future vision for the patient could be that's bigger than what the patient could see for themselves. So, yeah, keep going.
Which is the number of different levels you're capturing in this one slide. Everything from a self-report scale with the PHQ-9 to an external behavior, but that is actually more complicated to rate, number of fights, to really complex theoretical constructs like coherence and self-description.
Yeah.
And I think you're absolutely right. You need all those different levels to tell that story. And I think, not every field of medicine needs to do that, right? It's a little easier when it's all different measures that come off of a set of blood tests. But we need that range, and that's what's made it hard. But to have the sophistication to do all of these is, I think, a game changer.
Yeah, and I think one topic we haven't talked about in here for the last two, so the first few, PHQ-9, a number of fights would be self-report unless you have a collateral source. Home time and truancy can be automated. But the last two, we're really thinking about video and voice recordings as well as journaling to be able to understand sort of how is, you can actually have computational measures of coherence, right? And I'm sure the speaking AI conference is talking about this, but being able to rate how someone's coherence in themselves, in their descriptions of themselves has changed over time is a thing we can do now. So you can actually get with data in some sort of passive ways, all of these fairly straightforwardly. Any other questions? No? Come on up.
We'll do a Q&A real fast. We have like 5 minutes or so, I think. Okay. Do we have any questions to get them started, or should I start us off? I will just comment. One thing that struck me throughout all of this, of course, we love data and technology, and that's why we're here. But I think the point of this panel was to really think about, and I think almost everyone talked about this, either the human-centeredness, the empathy required, or, in Lindsay's case, I'm just so struck by your ability to be vulnerable and show that data, right? Andrew pointed that out. But that is a very personal process, and we have to recognize how difficult this can be to turn the psychological experience, I think, into data, right? That can be fairly impersonal, actually. And that's not an easy feat. It's not an easy feat emotionally, but then also in terms of actually presenting accurate data as well. So I think if you all can kind of talk about that, how are we as, clinicians or business, how do we develop tools in a way that truly taps the psychological process through empathy and vulnerability and all that. So someone can start. Yeah.
Yeah, I think it's a great point. And I don't necessarily know the answer, but I do think that, when I talk about a lot of this stuff with clinicians or people with lived experience, many people's first response is, well, isn't that just going to erode the patient-doctor relationship? Mm-hmm. Isn't data sort of the opposite of the thing we want to do? So I think it's a real barrier, and I think with the Silver Hill New York program, and we're already wondering, should we just never say the word data? Should we say this is all about more, we want to learn about you and just kind of bring the data in kind of covertly, because I think that is the real concern, that people feel like this kind of approach is almost like anathema to the clinical work we're doing.
Mm-hmm. Mm-hmm. Yeah, and if I could comment on that. So one of our clinicians that advises with us at Silver Hill, New York, and works with us is he's very clear that the data is not objective, right? All of the data is communication, and it's the patient communicating something. Even the sleep data, right? It's when they choose to wear their watch versus not wear their watch. We use Apple Watches and Oura Rings. When they choose to wear it or not, that means something. And so using the data as a means to facilitate communication and seeing it that way, as opposed to seeing it as this is an objective thing that exists and can just be given back to the patient and interpreted by the patient. That, I think, has been a really important part of what we've learned from the clinical. Yeah.
So I hear what you're saying, does it take the empathy out of it? But actually, both of you have great examples of how data, you said there was a person going, I'm not sleeping. And then at the end, you're like, everybody's like, no, you're sleeping. And you go, actually, you're right, you're not sleeping, this is why. And then there's all the stuff you could bring into it. And so I'm a psychologist, so I apologize for that. And I'm a cognitive behavioral therapist, so I apologize for that too. But
So am I. It's okay. We're in it together.
And it's
Yeah.
a good example of going, I don't feel like people are helping me. And then at the end of the day, when we leverage data, we're like, yeah, nobody's helping you. Yeah. And so until you went to McLean and they were able to go yeah, we're not helping you. And here's the reasons why. And so I think we look at data as this very sterile thing. But I think it's extremely validating when somebody goes, when I treat PTSD and I can show somebody, they go, I don't know, I feel like I'm getting better. I'm like, yeah, this is it. And it's extremely validating. And I think we need to get less afraid of data and feel like, oh, we're going to be, but like we don't have to, like you said, say, well, here's your blood test, see you later. But like exploring it in the way that all of you up there are talking about doing, which is very exciting right now, and to make sure that we help people.
I agree. I think it's a lot about the approach to the data. And so there's a way that data can be surveillance and shame inducing, and there's a way that data can be like validating and engaging and sort of empowering of the patient to tell their own story in a way that the clinician can't see. And so I think you're right that it's approach. We have to approach it differently.
I'll just chime in real fast and say people have to be trained to turn the data into a compelling, accurate story, right? And that narrative, to provide that kind of context is incredibly important. If you don't have the training to do it, right, you miss kind of like what Lindsay was talking about in some of her slides. You don't have that ability to do that deep phenotyping. Maybe it's even just time. Maybe you have the training, but you don't have time to really think it all through.
And I would just add, I think we were talking about an example of, maybe a first meeting about Q15 checks and how can we make them different. And I think the language was, we're going to be able to do away with them, which is really exciting from the patient experience and from the nursing experience. There was this visceral, like, like how are we going to keep people safe? And so talking about language and being empathetic and being vulnerable, highlighting the value of the data of like, we're not doing away with them, we're digitizing them, and you're going to see them in a different way, and we're going to take the time to explain to you what that looks like, and you can be part of the development process. And then we started these stakeholder meetings that the people who were interested in could join. And so I just think, to your point, being willing to be a little uncomfortable and the way you present it to certain groups of people is really important.
Mm-hmm.
Hi, Saib Khalsa from UCLA. I have a kind of more of a forward-looking systems question. Sometimes when I work with this, visualizing this type of patient data and talk to different groups, researchers, clinicians, there's always this 5 to 10 year in the future vision that's sort of like driving, like, okay, the implementation of this. And what's sort of clear to me beyond a lot of the issues highlighted at the patient level is that health system buy-in is going to be huge. And it sounds like with Silver Hill that's sort of like a prototype example of how to do it. It sort of like reminds me of the days in Epic, like pre-Epic, all the clinicians here who remember that, there's like a lot of institutional grumbling and change, and then it becomes the norm. So I'm just curious to get a perspective from you guys about what's the optimal approach to actually achieve that transition, assuming you're able to get some of the patient level buy-in, because ultimately that's going to be a key ingredient.
Yeah, I think it's a really good question, and probably one there's no optimal answer. I can tell you what we're trying right now. I think part of it is vision sharing, right? And like what's been really valuable in our partnership with Silver Hill is that we share a general vision and a willingness to learn, right? And to learn together and to sort of take that risk that we're putting data in front of patients now. We're creating a clinical model now, and our hope is that we can build the clinical model, the training protocols and programs around it, and then be able to expand from there and share that more broadly. But I think until we have the collateral, like you've seen some of these reports, until we have the case studies of how it works well with patients, how it really impacts care proactively, I think it's going to be hard to convince people that aren't like super cutting edge and attending this conference to buy in. And certainly until you have the sort of economic data that it improves care in a way that improves cost, you're never going to get the payers on board, and that's going to require so much scale. So I think we're on a journey.
I'll just comment that that we've sort of taken the champion kind of approach, which is like, so we're at McLean Hospital, part of Mass General Brigham, which is a very large healthcare system. McLean is a smaller sort of psychiatric satellite from the Mass General ecosystem. Within McLean, there are certain clinical units that are a little bit more interested in this than others, and so it took a while to figure out, like, okay, this is the unit where we can actually get the medical director and the nurse manager championing this to get like a definitive clinical QI project, which will then, in the best case scenario, allow the rest of McLean to maybe adopt some of those similar procedures, and then get on the radar of Mass General Brigham to say, hey, something interesting is happening at McLean, we should adopt this system-wide. that hasn't materialized yet. I still think it takes time to sort of go that route, but I think that's sort of the approach we've taken is start small where you can get a lot of buy-in, figure out what works, because there's going to be a lot of things that don't work. Find something that the clinicians find useful, get over that hump of it. It's you know, the amount of time it takes to learn it is worth it, and then start using that to sort of share it. But
I might also just add, there's a difference between retrofitting and building from scratch. And so one of the reasons we chose to do Silver Hill, New York as the program where we were focused on it is that we could build from scratch as opposed to trying to take existing ecosystems that already were ingrained and change them. So I think starting from scratch is the way to start. But.
Thank you, Ben Cuthbert, University of Toronto. So just listening to the talks, and I was thinking about one of the critical challenges we've had in mental health, which is limited measurement-based care. And if you look at other disciplines, doing blood pressure data collection to look at whether your interventions have worked or not is not questioned at all. Whereas in mental health, a lot of that resistance has come from clinicians. We know it works, but it's been difficult for us to actually do it in the clinic. So I was wondering, with all the passive data collection and the care journey which was portrayed, does it give us an opportunity to do measurement-based care in a different way, with all the passive data being collected, less input from the clinician really in terms of collecting the data, but the data is then presented back to the clinician? And if yes, how would we then look at getting coverage for that?
I mean, the last question is probably the easy one, which is the data has to prove that it improves sort of the care outcomes that are very expensive in the system, like hospitalizations. But I think in terms of taking one of the things we've not wanted to do is take the clinician out of the decision making at any point in time. And so we're actually thinking about passive sensing almost as a prescription, right? We assess the patient and we say, is this a patient where sleep data is going to be material to their outcomes and where we expect there to be a change in sleep, either positive or negative, that we need to track? And then that becomes the clinical recommendation to track that data. What's not worked super well in our limited experience so far is saying, we're going to track everything, blanket statement. That feels very researchy and it doesn't feel targeted or particularly useful to that patient particularly. I think patients, in our experience so far, want to know that you're giving them care for them that matters to them. And so it's actually been very helpful when it's targeted towards their journey and clinically recommended rather than a sort of blanket approach. But maybe that'll change. Anyone else?
Just to add on that, I do agree. I think the bottom line of this is to not lose sight of the patient with all that data and to work with them through that process, because they're the one that have the data in the end, and it's to again starting from scratch, but building that maybe new system with them in mind.
Yeah, I think just another couple of thoughts. The radiology wasn't a thing 100 years ago or whatever. So there became a time when we needed to create a new discipline of medicine whose job it was to collect and interpret a new kind of data, which then the primary doctor wouldn't communicate to the patient. So I think that's one potential model, is that if these data are deemed to be sufficiently useful, we'll start to empower, whether it's clinicians or other types of professionals, to get paid for collecting and interpreting that data. There are CPT codes now for going over data with a patient. So there's like remote patient monitoring CPT code, but also there's CPT codes just for reviewing like a sleep report with the patient. Now, not all the insurance companies reimburse for that yet, but it's been it's been created, so there's an opportunity for that. And then I think the third way would just be, as we see value-based care insurance models, if there are ways to take care of somebody that lead to better outcomes without the clinician needing to do a lot of other things that they would normally do by hand, then you can create a better provider experience while still maintaining good clinical outcomes. And so I think to the extent that healthcare systems can embrace these things, because if you think about sort of quadruple aim care, you don't necessarily have to improve the clinical outcome. If you can improve the patient experience or the provider experience or make something less costly, then we think that's ultimately going to be what insurance companies and others would want to pay for.
Thank you.
All right. Thank you all. Thanks so much for attending.